let's shift gears here, and to quote a former panelist, physicians may have a difficult time finding a good interventional radiologist, but probably not that hard of a time finding a good phlebotomist. And the role of plasma and genetic interrogation for lung cancer is here. It's not science fiction. This is something we're doing. We have multiple platforms that are being used. Of course, a minimally invasive approach. Chandra, can you give us a sense of where we are with plasma cell-free DNA and how we can use this routinely or under the auspices of a clinical trial, either or?
Yes, Ben, I think that the liquid biopsies have arrived, and they will probably change the whole therapeutic landscape and the prognostic and predictive landscape for full genotyping. And I think that it's probably of benefit in lung cancer patients when we need an invasive biopsy sometimes, and sometimes the patients actually are not willing to undergo a biopsy. So these liquid biopsies will probably be much easier.
Yes.
And what is now known is that these liquid biopsies have been validated in certain instances, especially for EGFR mutations and KRAS mutations. And they have a positive predictive value of close to 100% in those cases. And when we are looking at resistance mutations like the T790M mutations, the positive predictive value or sensitivity may be close to 79 or 80%. Thus, in the lay language, even if it is negative, there's a 20% chance that this T790M could be positive in the tissue. So I think that especially if we are going to give these targeted therapies as described by Mark, and we are going to change therapies with the availability of agents which targets those resistance mutations, we probably will be better served for our patients to do liquid biopsies and send it for circulating or cell-free DNA.
Yeah, I've been very encouraged by the data. There's been some nice data, as you alluded to, showing a very high positive predictive value of 100%. If it's positive, it essentially rules it in. If it's negative, however, you need to do the biopsy. I would say we're 96 hours in to an FDA-approved blood-based cobas EGFR test that just was announced. So I think this is something that is coming into routine care. So as you mentioned, yes, you are being able to identify these patients up front. Do you think it will ever circumvent the need to do tissue biopsy, or are we really wedded to doing this?
The technology is advancing very rapidly, and I think that we probably will be able to circumvent that, provided there is not a lot of heterogeneity within the tumor tissue, that you're not able to detect that in the DNA which is shed from the tumor into the blood. So I think we are there. We are not there yet 100%. So the sensitivity for detecting specific mutations may be still lower, but I think the capabilities are getting better as time advances.
Yeah, I would agree with you. I think there are many platforms out there that are coming to a physician near you that are saying that they can do genetic interrogation off the blood. Right. I think there's a lot of, there's certainly a need there, and certainly some of these platforms are sensitive and accurate, but none of these platforms, to my knowledge, have had concordance with tissue yet. The first prospective study to do this concordance with paired tissue was the data in JAMA Oncology recently. Do you see ever a time where there'll be the ability to do longitudinal samples of EGFR and see if there's a drop-in copy number that would be kind of like the story with BCR-ABL, with CML, seeing that?
I think that we are already seeing it. Data is being presented at this meeting where you see a 50% reduction in the copy number of the EGFRs, especially in patients when we are using the third-generation inhibitors for brain metastases and leptomeningeal disease. Yeah. You have started to see that in the periphery, in the liquid biopsies, the reduction in the EGFR copy numbers. And
yes,
so I think we are there. We're not there 100% yet, but I guess it's a good and a rapid advance.
Yeah. Any other thoughts about cell-free DNA and the routine use of it in clinic?
I think Chandra is right, and we should just remember that if it is negative, it doesn't really tell us that it is not there. And the other advantage is that potentially you may not find that on a particular tumor biopsy, given alteration, but maybe present in the blood. It's highly specific. So this may come from a source that you're not biopsying from. So that's a big advantage. I think it's really, in the next few years, you're going to see all those things.
And I think that if we get a positive result, at least we have it. So for the negative result, we may have to go and pursue further by getting tissue. But at least if you have a positive result, we can start the treatment in that case.
And it's often really helpful because you can't always get a biopsy in patients. Sometimes
Exactly.
there's not enough tissue and patients don't want to undergo a second biopsy, or again, like I was saying before, time is important and you don't have the time to do another biopsy. So I think both at pre-treatment, when someone's first diagnosed, and then at resistance, it can be really helpful and quick. You can get results quickly instead of having to do a biopsy, get the tissue, send that for testing. So
The results
really
are
be-
in days rather than weeks.
right,
Right.
it's
From
really
48
fast.
to 72 hours, you're able to get it, as you just said.
There is one problem though, the reimbursement, because you'll be doing this again and again, and especially if you're doing a large panel, then the issue is whether those things will be reimbursed, and that can be the bottleneck for a while.
Well, we seem to have gotten over that with PET scans. Despite the fact that PET scans to check response are not approved by any guideline, people do them all the time. And what does a PET scan cost at your institution? $7,000, $8,000?
Well, it's come down quite a bit.
Yeah, but
they have
it's
to come down.
So these things will get worked out, and I think the important thing is if they really impact somebody's health, accelerate care, help you get the right drug, it's going to eventually get figured out.
Yeah, I agree. I think a rapid test like this that's minimally invasive, that's a fairly accurate molecular proxy of disease where we can make treatment decisions based on these tests. I can tell you at our institution, we've had a tough time with tissue stewardship of the biopsy, getting to the pathologist, getting it resulted, and then getting it back to the treating oncologist has been a challenge. We've had turnaround time days that exceed 21 to 28 days. So for us, this has been a welcome change, and it's a win for the patient in a lot of ways.